our side for showing interest to learn palliative care. I understand all these participants here right now they are someone who have identified suffering at some point of time, and that's might be the reason why you are here, so that you will understand how to at least you are looking for ways to address those sufferings. So I'm so glad to be a part of this program and welcome you, wholehearted welcome to each and every one of you for this program. And we were really looking forward to meet so many people to treat the suffering of patients with respiratory issues. So thank you so much for being a part of this program. So today we'll be starting with the concepts of integrating palliative care into the pulmonology practice. We have two faculty members today for delivering the session, followed by a presentation of patient story. So today we have Dr. Rajam Iyer and Dr. Sujeet Rajan. Dr. Rajam is a very well-known pulmonologist in Mumbai, more than 20 years of experience, but I will introduce her as a palliative care physician, which I like more. But yeah, she practices both. And she is doing her, post-graduation again in palliative medicine from Cardiff University, UK. And Dr. Sujeet is another pulmonologist with many years of experience and who's working in Mumbai with special interest in interstitial lung disease and airway disorders. And Dr. Sujeet is also, I understand, is very close to palliative care. So so it's a pleasure to welcome you both as faculty for this program. I think they were with us for so many months to design and execute this program as our mentors. So thank you so much, both of you, for all the hard work, and welcome you to this program.
Thank you so much, Sridevi, Rajalakshmi, Dr. Sunil, and the entire Pallium India team. Pallium India is very close to my heart. I think the first training I got in palliative care was from Pallium India. So I'm really glad to see so many interested, young, busy pulmonologists who have joined after a day's work. And not just pulmonologists, I believe a few intensivists as well as a few palliative care physicians. Like Sridevi said, this topic is very close to both Dr. Sujeet Rajan and my heart, and of course, Pallium India's heart. And without wasting much time, we'll go into talking about the scope and need for palliative care in respiratory medicine. As you all will agree with me that even healthcare professionals think that palliative care is meant for patients with cancer and for patients at end of life. And by the end of the 90 minutes today, we hope to bust that myth with all of you and show you and convince you to some extent of how important it is to integrate palliative care with not just respiratory medicine, but with all specialties. And without wasting much time, I'll start sharing my screen. I also request each one of you, you're a busy consultants, you are all used to and probably a bit bored of webinars, but I seriously request you to make it an interactive session so that it's interesting for you and for me. Stop me at any time. Let's have a healthy argument and discussion. Please put in the chat boxes with your queries. Sridevi and Dr. Sunila will both look. Sunil will look at it, but let's make it interesting and interactive so that we learn more from each other. And I've always believed that there's always a lot to learn from the people who participate. So let me start by telling you my journey started as a respiratory physician. But I think Sujeet and a lot of my patients will agree that my care towards patients with chronic advanced respiratory diseases has changed after my training in palliative care. So I think I've become a better human and a better doctor. And I think I've truly now aiming to become a health care professional, because that's what I do for my patients now. So to start with a slide to just emphasize to all of you that in India, we have a rise in the non-communicable diseases. And for the sake of this talk, I would love to convert the C into non-cancer. So if you see this data, a lot of Indians are suffering from this chronic ailments, which include cardiac, diabetes, hypertension, dyslipidemia, respiratory illnesses, as well as tuberculosis. And if you realize, most of these conditions are controllable, not curable. And beyond a particular stage, these diseases then become incurable due to its complications. Yes, palliative care is very important component of cancer. And in India, we do add 1 million new cancer patients every year. But if you compare with the number of Indians affected by non-cancer chronic illnesses, it is way more than that is affected by cancer. So the question here is, if cancer needs to be integrated with palliative care and the treatment of cancer needs to, how is any chronic, progressive, incurable illness, why should it be bereft of palliative care? So, and the staggering number of Indians who get affected by these non-communicable diseases is high, and it is only increasing. Focusing on respiratory medicine, if you see, we are in a situation where we are seeing more and more patients of drug-resistant, multi-drug resistant, and XDR tuberculosis, which equally need the significance and importance and attention of palliative care. Recently, I had a 52-year-old lady with progressive interstitial lung disease and multi-drug resistant tuberculosis. She was a single mother of 2 girls, aged 20 and 25, and those 2 girls were distraught at how to look after their mother. Neither was the TB getting cured, nor was the interstitial lung disease getting cured. Their bank balance was fastly dwindling, and they really had no support to look after this young 52-year-old mother who was not even told the exact prognosis of her illness. And the first thing the patient told me is, I want to get better. I want to be cured. So you see, even infectious diseases, which can actually be totally cured, can add to the burden of patients who need to be looked after. Again, the incidence of airway diseases, both in terms of asthma and COPD, are also increasing in India. And Sujeet will agree with me, and so will all the pulmonologists in this group, about the rising trends of more and more interstitial lung disease we are seeing in this country, not to forget the pandemic, which I will come to at the end of my talk. So coming to the way in which the people in this world die can broadly be classified into these 4 graphs. So the graph A and graph B are the ones which are probably not the purview of this talk, but sudden death is something that these people are lucky. And to let you know that only 7% of people die suddenly. The rest of the people go through various stages of bed-bound phase. Graph B might be compared to a patient who's suffering with cancer, who enjoys a decent quality of life till there is a sudden deterioration to death. The focus of today's talk will be organ failure. And as you all know, as intensivists and pulmonologists and internal medicine people, that when you get diagnosed with a condition like chronic obstructive pulmonary disease or an interstitial lung disease, this patient then, especially with COPD, can live a life of at least 10 to 15 years with this diagnosis, which is punctuated by frequent hospital admissions, which is depicted by the dip, where we as pulmonologists see these patients during acute exacerbations only. What happens to these patients once they go home? What is their quality of life? Are they independent? Are they able to go to the toilet on their own, care for themselves, feed themselves? So these are the important questions. Our patients with non-cancer diagnosis do not perceive COPD and interstitial lung as life-threatening, as life-limiting, and it is therefore they lead a life of prolonged period of time with a very high symptom burden. You realize that after each hospital admissions, our patients never reach that quality of life that they got admitted in. And it's a slow deterioration. It's a slow worsening of their quality of life till death. And this is what we need to focus on when we look at patients who are diagnosed with chronic incurable respiratory conditions, that we need to overall not only improve their survival or quantity, but also focus on quality of life. And unfortunately, in our training in medicine, we are not taught to focus on quality of life or taught to communicate to patients about the prognosis or natural trajectory of the illness. And we are definitely not taught to talk to patients about death and dying. And all of this will be focused during these 7 sessions that you'll have starting today. So if you can compare a chronic obstructive lung disease, or for that matter, any chronic illness, to falling off the skyscraper, this is exactly what happens to our patients. As they are deteriorating in their clinical conditions, We, unfortunately, are the doctors who have seen a lot of patients with COPD and interstitial lung disease. So it is our onus to foresee and foretell which patients are not going to do well or which patients are on the slippery slide to end of life. So it is therefore important to punctuate our patient's fall with unhurried, sensitive, timely conversations, preparing the patient and the family for an emergency, and therefore letting them have time to process and analyze so that they know and they're better prepared in an emergency and not where all hell breaks loose. Because the manner in which you land depends on the way you fall. And we really need to break these falls regularly to see to it that our patient and family is better prepared. What we do now is wait till the patient is probably on the first floor, and then we try to explain that it's a critical condition. And Sujeet will agree with me that after half an hour of talking to the patient, the prompt question that the relatives ask, but there's nothing serious, right, doctor? He will become all right once we put him in the ICU. So it's important that we need to understand the emotional bandwidth that the patient and the family are going through when the patient is rolled into the ICU, and no difficult conversations have happened when the patient has been deteriorating. So what do we aim out of this 7 sessions is to integrate palliative care early. The earlier we do it, we have time to build rapport. There is time for the patient and the family to process. And believe me, it's a win-win for the pulmonologist, for the patient, for the caregivers, as well as for the palliative care physician and the intensivist. When every detail is being discussed, we know the goals of care, we know the action plan, there is much less level of stress. So we would like to integrate palliative care early, continue it towards end of life, and palliative care also continues in the bereavement, where we support the families who have gone through difficult caregiving as well as difficult situation with the patients. So the prompt comes the question from pulmonologists: how can I talk about palliative care to patients with COPD and ILD? And it's like giving up. It's like losing hope. Imagine a pulmonologist telling the patient and the family, I think you should meet a palliative care physician. So therefore, this timing of referral is crucial for you pulmonologists who are busy in their practice. It's very difficult, I know, to talk and answer endless questions of anxiety and fears from your patients and caregivers. So this research was done in England, which is very interesting. And all you need to do is, when you look at your patient who is on the slippery slope down, think and in your mind, ask this question: will you be surprised if this patient were not to be alive in the next 1 year? And if the question answer in your mind is no, that is the time for proactive palliative care. So it is not a question of losing hope or referring to us very early, but it gives us enough time to have a shared care with patient. And Sujeet always introduces me as a part of the team. It is not abandoning your patient to another doctor, but it is a shared care by pulmonologists and palliative care, so that the patient and the caregiver feel better supported. And just to indicate what exactly are the points for referral is any of these 2 points in COPD. So if you have an elderly patient who has recurrent hospital admissions or MRC grade 4 or 5, who's requiring 24/7 oxygen, whose lung functions have deteriorated, or requiring an ITU admissions with comorbidities. So if the patient satisfies any 2 of this criteria, that is the time to realize that the prognosis long-term is going to be poor and he needs the support of palliative care. And this is described beautifully in these 2 documents, which Pallium India will circulate to you, which is, 1 is the gold standard framework and 2 is the blue maple from Kasturba Hospital, Manipal, which gives you indication of referral in every chronic condition of every system. I request you to please read this, because it really will improve the care experience of your patients, and your stress levels will definitely reduce. This is also important for me to tell you that the research published from the West has clearly shown how patients with non-cancer get much less integration of palliative care. And it's so therefore not just an Indian phenomenon where 80% of cancer patients get palliative care, while only less than 2% of non-cancer patients get. And imagine the number of patients in India who are afflicted with non-cancer, progressive, incurable illnesses. Also, The other interesting factor is that patients with chronic, incurable advanced respiratory diseases admitted in the ICU ended up getting more aggressive interventions, fewer control of distressing symptoms, and unfortunately ended up having more aggressive treatment in the ICU. So focusing on the poor quality of death that they had, and which also is important to remember that we in India today rank 59th in the quality of death index. So it's important as to how our patients are dying. Have we become doctors only to cure, or have we become doctors to comfort and care and alleviate suffering, like Sri Devi mentioned? It is important for us to realize that our patients and caregivers suffer during this chronic illness journey, and we can make that journey better for them, tolerable for them, and bearable. Yes, you're not able to cure everything, but we can make a difference by being their friend in this difficult journey. Another interesting graph I want to show you is of all the patients admitted with an acute exacerbation of COPD and type 2 respiratory failure, even on discharge, after, you can see only 25% of patients were both alive and well with a decent quality of life. Almost half of our patients get readmitted. So this is another interesting thing we need to know, because as pulmonologists and intensivists, we focus only on the acute phase of the illness when they are in hospital. And we really need to focus on what happens to these patients and their caregivers at home to improve the care experience and to see to it that we offer them holistic care. So again, a focus at more than 60 to 70% of our patients are dead. 40% of our patients are dead within 6 months of admission in the ICU. So are we admitting and selecting patients correctly for the intensive care is another thing in a country like ours, which has a resource crunch. So typically, when we all train to become MD physicians, this is exactly what we are told to evaluate when we have a patient of chronic respiratory diseases. What we completely forget is what are our issues of our patients who suffer this breathlessness. Do we actually ask them about how dependent they have become, about the loss of role, about how socially isolated they are, about the frustration, anger, depression, and also the constant anxiety and fear of death? So these are the other issues of breathlessness that patients have, which we as pulmonologists are never taught to think. So we need to change the way we take our history. Are you breathless? Is your breathlessness better? Is not the right way to elicit the right history. We need to talk to our patients and ask them, what have they given up because of their breathlessness? Or what is it that they have stopped doing or they can't do anymore because of their breathlessness? Because that is going to open our Pandora's box and reflect on how our patient's quality of life has dipped. He has stopped meeting friends, or he has stopped going for a walk, or he has stopped going to the toilet alone. It speaks volumes of how poor his quality of life is. So another interesting thing which I would like to focus here is the breathing, thinking, functioning model, which all people in palliative care are taught to think about. Our patients are constantly breathless, which is looked after by the pulmonologist, and the patient has increased work of breathing, use of accessory muscles of respiration, and he's constantly at a high respiratory rate. Imagine living like this day after day, hour after hour, minute after minute, and the only thing that is active in this person is the mind. So he is going to be constantly anxious, constantly worried. What is going to happen to him? How is he going to die? Is this death? Am I going to die the next minute? And the mind is constantly working. And with that, he's going to get more anxious and therefore more breathless. Lastly, because of his breathlessness and his anxiety and fears, he is going to start doing less and less, and therefore get more and more deconditioned, and therefore become more and more breathless. So our patients are caught in this vicious cycle of being breathless because of the underlying pathology, being anxious because they're breathless, and because of being breathless and anxious, they do less and less. And palliative care, with its multidisciplinary team, breaks this vicious cycle with the help of the pulmonologist, who is the primary physician, with the help of counselors and psychiatrists to help patients overcome and cope their anxiety, and physiotherapist with rehab so that the patient is able to perform decent activity with his limited available lung functions. So it's very important that we work together as a team. It is not that the curative phase ends and the palliative care starts. It has to be integrated. We have to look at a marriage between the two specialties. This is what our patients go through, which is chronic breathlessness syndrome, a topic for the next talk, which is on next Thursday, done by the person who's actually coined this term. So we are very lucky to have Professor Johnson here. And this only classically describes how our patients who continue to be breathless because of their underlying pathophysiology, despite being on optimum treatment for that, and how this breathlessness affects them psychologically, socially, and spiritually, and they continue to remain breathless, and how we can address their breathlessness through non-pharmacological and pharmacological interventions, which will be described in detail by Dr. Professor Medium Johnson next week. A little short note on morphine, which we have started using for patients with chronic breathlessness. Most of my pulmonology friends are quite shocked that I do use this for chronic breathlessness. Enough research has been done on safe use of low effective morphine to help the patient relieve the sensation of breathlessness. Again, will be dealt with next week. All of you will agree that it's not just breathlessness, but cough, pleural effusion, hemoptysis, and hiccups are also other distressing respiratory symptoms which can be palliated so that the patient has a decent quality of life till death. Last few slides on the pandemic and the palliative care of how the COVID pandemic, I cannot not talk about it, really emphasized the need of palliative care. It has been a humanitarian crisis across the globe. It's not just for patients who are unwell, but even those who are well and isolated at home. Not just patients who had COVID, but patients with other chronic illnesses or the elderly, the vulnerable population, as well as patients who suffered an acute illness. It's very important to realize that during the pandemic, A was the treatment of COVID, the way it affected the lungs, the way it affected the healthcare professionals, the isolation, as well as the grief and the bereavement, which was also complicated. And I think if palliative care was a part of our medical syllabus, we would have all handled this pandemic way better. And I think we could have been a great support, not just for each other, but also for our patients and their family. So COVID actually got this into sharp focus of death and dying and about what we were doing as doctors with respect to medical ethics. Are we selecting the patients correctly? Are we putting the right patients in the ICU and on the ventilator? Are we those patients whom we couldn't save? Did we give them aggressive comfort care till the end? And how did we talk to patients and caregivers? All this was put to test during the COVID pandemic. And especially what brought into focus was palliative care in the ICU. So during the pandemic, we had experiences of not putting patients on ventilator, withdrawing patients who were doing poorly. And all this is medically and ethically correct, but it obviously needed good communications and documentation. And that is another aspect which will be a part of this training session. So very, very important how palliative care could have changed the way we handle the pandemic. And we have this huge burden of the post-COVID fibrosis, which again, I'm sure all of my friends across the country are seeing. And it is not easy because these patients are mentally fragile, physically upset, and these are the ones who are absolutely fine before they got COVID. So few patients, of course, we have a few patients who recover in 8 to 12 weeks, but there are a few people who continue to have severe disease, and we probably will need a lot of palliative care support and integration for these patients. This is just a graph to show how COVID fibrosis can progress, and those which deteriorate, like I said, will need palliative care. So the whole idea of this talk was to tell you the scope of palliative care in respiratory medicine, the need, and please remember those people at the end of life, their needs are similar irrespective of the underlying illness. All those patients who are dying will require handholding. The caregivers do require support, and those of my friends and colleagues who have lost a dear one will realize how important it is to feel supported at this very crucial time of losing a loved one. And to end my talk, I think it's very important that we die only once and we live every day. And we really need to focus this same funda for our patients also, because we need to improve their quality of life, add life to their years and not years to their life, and see to it that we make their care experiences worthwhile, not just in life, but also in death. Thank you.
Thank you. Thank you so much, Dr. Rajam, for that opening talk. Would you like to take questions now, or should we start with Dr. Sujeet and then we take questions together?
Either way, if there's a burning question about my talk and anybody wants it sorted, please, I'm happy to take it.
Yeah, we'll take 2 minutes just to see whether there are any questions. So if there are any questions or comments based on Dr. Rajam's talk, we can take up that right now. Either you can unmute yourself or type it in the chat.
Hello, I'm Dr. Radha. I'm an anesthetist and intensivist, basically. And I have worked in Iyer Cancer Institute, just by God's grace, in palliative care for 2 years. And I've just got a query, and God's grace, I've had the opportunity to listen to Dr. Rajam Iyer in 2020 Tata conference. So one query alone, in the slide which you had shown, the data for when patients are getting admitted, and then the outcome, 25% only survive and 44% have readmissions. What was the criteria? Is that any age-related factor?
No, I think these were, sorry, thank you for the question. These were patients admitted with acute exacerbation of COPD with type 2 respiratory failure.
Any age?
I can share the article with you, ma'am, through Palliative India. And
because that is
because typically, yeah, in our country, COPD diagnosis usually is 60, 65 plus. So I will definitely, and by the time they reach type 2 respiratory failure, unless they're chronic bronchitis, they're usually definitely older. But this is an international data. I will share the paper with you for sure.
Because
I have the link. Yes.
Because that's a very useful thing.
Yes.
Because
age is an important.
People don't realize at that age, when they are, like, as you said, the general functioning itself is at a lower ebb. And just one more thing alone, I've had practical experience in using morphine in small doses when I have been in Iyer, and young patients, like 40-year-old who is breathless, he will not have pain at all. No pain, because I did pain and palliative care there. So they will not have pain at all. I would start with a 5 milligram 8th hourly dose or a 12th hourly dose. And in 2 days, they will get better and go home, and they'll be happy to continue the same. So that is very, very useful and gives a very good quality of life. So
thank you for sharing this experience, because opioid phobia is persistent across with physicians, with patients, and caregivers. So I think if
physicians themselves are hesitant to use, but only thing is, it's a titrated dose has to be given, and it has to be explained. As I said, I have used for patients who never had pain.
Yeah,
they'll be a 40-year-old and not in pain at all, just with the symptom, and it works with, they'll be having a mask and everything with supplemental oxygen. But once you start this, it works so well. Even with 5 milligram BD dose, they will settle, or something in due course, they may go up to 10 milligrams BD, and they will have better quality of life.
Yeah.
Thank you very, very much.
Thank you. Thank you for sharing your
thoughts. Please share that article, please.
Yeah, I will.
Thank you. Thank you for sharing your thoughts and your experience on managing breathlessness. Is there any other question, or I think we can move on to Dr. Sujeet's talk, and then we can take up questions together. Dr. Sujeet, over to you.
Sure. Thanks, Rajam, for that great talk. And I will just share my screen here. Yeah. Can you see the screen, Sridevi?
Yes.
Yeah. Right. So the journey through this palliative care, and it's wonderful to see, first of all, so many people logged in. And I can see people I know, people who are busy in respiratory medicine. And so I thought my talk will have a little bit of philosophy in respiratory medicine practice as one grows older, combined with why it is so important to integrate palliative care. And I can tell you it's not for just people who grow older, because we realize pretty late in practice. And when we start practice in chest medicine, and I can very clearly recollect this, you're working towards building that practice. And your success is defined by the number of patients you see, your wait lists, and the bed occupancy in the hospital that you work at. And you believe, or you're made to believe sometimes by hospital managements, that this is a successful respiratory physician. And when you struggle and you work hard and you work very long hours and you build that, you have very good numbers, which many of my colleagues have, I would say, long wait lists, excellent bed occupancies. But you really need to sense, and this is very important, that your time for your patient is getting compromised here. And also your patients are leaving your clinic unsatisfied. And it took me some time to realize this, I think, and a lot of my friends, juniors, seniors have all gone through this. But, when a patient leaves your clinic unsatisfied, I think, and if you were to get that feedback, and if you get that feedback very often, it makes you introspect on what you're actually doing in sitting in that room. And then when you end, or when you're about to retire, as many respiratory physicians do, and some don't till they die, then you have excellent numbers, long wait lists, excellent bed occupancy, but you don't have time, not just for your patient, but you don't have even time for yourself. And I think that is extremely frustrating.
Dr. Sujeet, sorry to interrupt.
Yes.
The slideshow is showing something. It's showing differently. We can see two videos.
Two videos? Okay, let me stop sharing.
And now it's okay. Before you stop, it was fine.
One second. Can you see the slide?
Yeah, perfect.
Sir.
Okay, great. So as you end your practice, then you suddenly have you don't have just reduced patient satisfaction, you actually have reduced joy in life in general. And that's hardly a way to end a respiratory physician's career. And I see a lot of people having had this experience, and I don't want this group, and especially the younger people in the group, to go through this. Now, when you go on, when you look at how you start and you end well, which is really what we are talking about here, and that's where it's not just about palliative care, but this is something that is not taught, as you know, in most medical colleges in the country. And you have a few people like Radha, Rajam, and who have worked in centers where palliative care is entrenched, but you really need to figure this out on your own. And for the younger people, I don't want them to figure this out once they're middle-aged and elderly. It is your practice, your patient's life, and your life that you're dealing with. So be reasonable, don't struggle, and value and respect time very, very well early on in your careers. Why do patients come to me from another chest physician? Are the slides projecting well now, Sridevi? You can see them clearly?
Yes, perfect.
Yeah, okay, great. So I often think of why a patient comes to me from another chest physician, and a very competent chest physician sometimes. And invariably, when I see that patient and I say, hey, this has been seen by a colleague who's superb, who's probably better than me, more well-read than I am, I realize that it's usually an inability to give adequate time to the patient's concerns and questions. So if I ask the patient after 20 minutes of the consult, why did you come to me? The answer will be usually, I never got time to get my questions answered. Communication was not effective. No one talked about chronic breathlessness. And this is something that I would strongly advocate respiratory physicians to look at. No one talked about it. I mean, it's just it's a done deal. You have to be breathless if you have severe COPD or severe ILD. You have to live with it. We can't do anything about it. And I'm so glad there's a session on that later on in this series. And no one's really understood and probed the social and financial issues. And I always get surprised when I refer a patient to Rajam on the wards, and the next day there are at least half a dozen points in the history which I've completely missed. I mean, I wouldn't even have had the time to ask those questions, but they're as abstract as someone having zero caregiving at home or going through a terrible social life, which has actually brought them into the hospital or increased their suffering. So this is what the average respiratory physician is just not able to deal with, I can tell you. And if you just integrate palliative care, in the sense, decentralize that time to someone who's involved in this, you will see how your practice changes actually, and the satisfaction levels go up, which is what I will come to. And in Yale, they did a study about what patients want from their doctors. And it was amazing because patients were interviewed and they said they want a doctor whom they can trust, a doctor who's competent, and a doctor who puts the patient's priorities before anything else when making a management plan. And sadly, at least when I did medical school 25, 30 years ago, two of these are not taught. I mean, it was never taught to me, how do I build a patient's trust? Neither was it really emphasized that the patient's priorities come before anything else when I write out a prescription or plan a management. So competency is taught. That's why we have amazingly competent physicians across the world. But if those other two factors are put in, you would be, in inverted commas, a rock star in clinical practice, I can tell you. So it's just those two things we really need to work on. And that's where the palliative care physician really ends up, because that's their full focus. Palliative care physicians are so focused on that part. It's something that we've often missed. So it's just a new set of eyes. It's no huge set of special skills that comes here. It's the listening capability, the focus on what the patient wants or the family is able to cope with. It's a lot of time decentralized from the respiratory physician and trust building in a team. So this is a team, because the moment you let go of your responsibility to another consultant, the patient thinks they've lost you. And that's not what we are working towards. And then someone would ask, why a team? Okay. Why a team or a joint clinic? And this is hard sometimes to answer, because when you look at teams, it always sounds complicated. It's not at all complicated, trust me. It just allows everyone to be on the same page. And your team member doesn't even have to be in the same hospital sometimes, but if they're in the same hospital, it's luxury, like I have in one hospital, but I don't have in another hospital. It markedly improves the patient experience, and patients who are quite advanced in the disease process, who are not able to make multiple hospital clinic visits, costs reduced, because if you call the patient on the same day, it reduces costs. And sometimes the patient has to see me and a palliative care consultant on different days. But if we're both at the same institute, I can just pop into the room and say, okay, I've heard from her what you need, what needs to be done, and I go along 100% with it. So a lot of this, and of course, virtual consults have completely changed. I mean, after COVID, the virtual joint consults are so huge, where the whole extended family across the world can participate, in fact, sometimes when it comes to decision making. But the patient is usually the focus of everything. And so having the patient on that virtual consult is very, very important. Coming to the primary objective, why do you want to integrate? Improving quality of life, as Rajam mentioned, and improving quality of death. So often a patient asks me, why palliative care? What is a palliative care physician? And so I often use the word supportive, because palliative, even from my colleagues and classmates in the medical profession in the United States, seems to be synonymous with end-of-life care. And this is a challenge you all are going to face very often in clinical practice, that the moment you say the word palliative, your own colleagues in the hospital think it's end-of-life care. And I was surprised when someone from New York in an academic institute, a colleague of mine, thought that palliative care was only about end of life. And that's just one of the sessions in the whole series, as you will notice. So what I tell the patient is that this consultant on our team is going to focus on the quality of your life. And of course, I don't say the quality of your death right on, but I say we're going to focus on the quality of life. And as you get more sick, improve it to the best possible. And if they do ask about death, we're going to say, we will improve that quality as well and make that as comfortable as possible. So you're going to learn a lot about this in this whole series, but this is the primary objective of integrating respiratory and palliative care. Our quality of death in India is hopeless. As you can see, we were 67th in 2015. I'm not saying it's hopeless, but it's not the worst in the world, but we are 67th in the world out of 200 countries. And we have moved up to 59th 3 years ago, which is good. But when I looked at the quality of death across the world, Costa Rica is 5th. Costa Rica is such a small country in Central America. If their quality of death is 5th ranking in the world, the UK is the best, by the way. I think there's so much to learn from smaller countries with sometimes even less resources than we have. Many patients routinely undergo expensive, marginal, non-beneficial treatments, and that's why the quality of death is bad. And this inadvertently, and so the physician thinks he's doing everything possible and he's, God's own creation for his patient, but this has actually inadvertently worsened the end-of-life experience. Does wealth matter in quality of death? High-income countries score a little better, but the differences between high, middle, and low-income countries are not statistically significant. So just because you're richer, it doesn't mean you get a better quality of death. What clearly matters and what's made a difference, and that's why we integrate, is uninterrupted access to opioids and other essential meds. So you need to, my palliative care physicians know exactly where opioids are available, how to access them. Evidence-based, equity-oriented policies, a personalized patient-centric approach, public education and promotion, and mandatory, of course, palliative care education to all healthcare workers. And so we have seen that change when we had palliative care at our hospital, the change in the nurses, the change in the resident doctors, everyone's attitude changes towards medical care when that dialogue changes. What correlates negatively is really lack of recognition that end-of-life care is a human right, no integration of palliative care, lack of investment in it, hospitals not appointing consultants, poor communication, and not giving your patient autonomy to make end-of-life care decisions. And of course, not recognizing cultural issues associated with death and dying. And as Felicia Knoll, who was the first author of the Lancet Commission report on palliative care in 2018, said what is worse than chemo is actually not having the choice to have chemo. And I think that sort of stood out in that whole commission report to me. I mean, this is something that we should not deny our patients. So how do you actually sense this trust, build trust? And you may ask me, okay, but how do you do it? Is it, there are no textbooks on how do you build trust, or there may be textbooks, I haven't read them, but I think first you need to change your mindset. Mindset change is very important, and a lot of people talk about demonetization being terrible for our country, but I have a little different take on it. I think it changed mindset. And when mindset changes, a lot of things change. We have the highest UPI transactions in the country, in the world right now. So when you change mindset, people tend to change. I'm not saying everyone does, but there is change. And if you see that patient with another set of eyes, it makes a huge difference. You just sit back and suddenly stop your respiratory medicine detail that you have always learned and you've always been trained to do. Keep that going, but just see the patient briefly with another set of eyes, and then you'll know what they need, which you sometimes just don't have the time in your respiratory medicine practice to deliver. And if you don't have a palliative care consultant, you'll have to do it on your own. And that's why I guess many of you are here on this series. And change your goalposts from how many patients you see every day to and how much you earn and how many patients are admitted. Change those goalposts, and when you change those goalposts, you'll come home a much happier individual than a person who comes home to his family feeling tired and exhausted all the time. As Charles Goodhart said in his law, when a measure becomes a target, it ceases to be a good measure. So if your hospital is defined by the fact that it's full. That's a successful hospital. Bed occupancy is full. That is not necessarily the best hospital in the city. Measures, however, are important, but what measures? You have to look at the measures. So if you can't measure it, as Peter Drucker, the management guru, said, you can't improve it. So you have to have some measures. And this is what you should measure. How many patients are staying in the hospital unnecessarily on invasive ventilation, renal replacement therapy against their wish, higher costs against their wish, drug side effects when they never wanted to even be in the hospital, and the dependency on caregivers, which is so, debilitating, not just to the patient, but to the family. So I would change goalposts to how many patients leave the clinic satisfied. And we are going to try and do this study actually in our hospital if the ethics committee approves it. That's going to be a challenge, I sense. That how many patients leave our clinic satisfied, how many patients with ILD and COPD, or for that matter, any chronic lung disease, are suffering less today. So if you ask your patient when he comes in, how are you compared to last time? Or what are you doing that you could not do earlier? Or is there something that you want to do that you're not able to do? Change those questions a bit. And how many patients get discharged satisfied with the care? When you start focusing in this way, it changes a lot of things. So to conclude, chronic respiratory disease, you will never be able to manage as a respiratory physician without being either trained, as I'm happy all of you here are, or being associated with a palliative care team when you have a larger practice. Wealth matters. I am not saying money doesn't matter here, but it is not often correlated with better care. Remember that. Measuring satisfaction from the patient satisfaction, quality of life and death are extremely important endpoints in overall healthcare policy. And I think this is what we should be looking at the national level. And integrating palliative care with chronic respiratory disease management is certainly going to be the future. Otherwise, you're going to have a lot of unsatisfied patients leaving your clinic and the hospital post-discharge. Thank you very much, and I will stop sharing.
Thank you, Dr. Sujeet, for bringing in another dimension through your wonderful talk. So we'll take up a few questions before we move on to the patient story-based discussion. So either you can have some questions, or if you want to share, or if you want to comment on what we have been hearing, please unmute your mics. So there were a few chats coming up again, not questions, but really comments like, yes, we are in a country where we believe that the ancient philosophies surrounding death, where it was kind of normal, but then we don't essentially practice that when someone has died. Are there any questions or comments? We really want these sessions to be interactive, very, very interactive. So we are expecting some comments or questions from your side.
I'm Dr. Anup here. I have a question.
Yes, Dr. Anup, please.
It's about revealing the diagnosis to patients with malignancy. More often than not, as an usual practice point, what we do is we tend to tell it to their spouses or their children, and then decide whether to tell the patients whether the diagnosis and what stage they are in. It's usually we do not discuss the treatment options with the patients. That is what is happening in our setup. What is the consensus or opinion on this?
So Anup, can I take that, Rajam?
Yeah. Go ahead.
So this is a very important issue, Anup. And I think are you talking of the outpatient setting or the inpatient setting? May I ask?
I think it's either.
Particularly inpatients.
Inpatient. Good point. So I think when we see that kind of a situation, it's two issues arise, Anup. One is whether you should tell the patient directly, which I notice many consultants don't. And the second is when you do it and how you do it. I think we're going to have sessions on that in the on communication. But I just put two things here. One is it is the primary consultant's responsibility, in my view, Anup, and not the oncologist's responsibility. It's very easy to say, okay, the oncologist will come and tell you. And I think that's a huge burden on the oncologist you're giving. And if this is a patient admitted under a pulmonologist, and that patient has come to you trusting you, you know that very well. You know, when a patient gets admitted, diagnosed as lung cancer by us, they don't want to suddenly see a new face who's giving them an adverse prognosis. They want to hear it from you. So it's extremely important to first counsel the family that you're going to talk to the patient first. And the family often has a great opposition because they've obviously landed their hands on the report before the patient very often. And so I tell them, okay, you may have the report with you, but I am going to discuss this with the patient tomorrow morning, and we can take it one at a time from there. And you face a lot of resistance from families, but you must stand your ground here. You know, the patient comes before everything else. Now, then they would say the patient is going to collapse, the patient will get depressed. I think the right thing to say is that we are there if the patient collapses, and the patient, if there's acute depression, we'll deal with that as well. But we will tell the patient in the morning that there is some adverse news, and would you like to hear it up front, or would you like us to discuss it with the family first? 99% of patients whom I've talked to about this, unless they're hard of hearing, okay, have said they want to know what's going on. And then, of course, there's a way to do it, which will come up in communicate how you break it, and never do it in the evening or night, the next day morning. And as someone rightly mentioned to me, you know, when a company does badly on the stock exchange, they're penalized if they don't report a loss, right? So if a company does badly, SEBI is going to fine you if you don't report a loss. The same way, I feel a hospital should penalize a consultant if they've not broken bad news to the patient and instead told the family. So these are ways in which you could tell them. And of course, most importantly, ask the patient, the caregiver who doesn't want the patient to be told, that what would he like if he was in the patient's place. And most of them will tell you they would want to know the diagnosis.
I just want to add to this, Dr. Anup. Yes, we are going to have a detailed session with regarding collusion, but we can't afford to forget medical ethics, another thing which we are not taught in our curriculum. And the first pillar of medical ethics is autonomy, and it is the patient's right to know. And the most important thing is, then most relatives are trying to protect the patient out of their love for the patient. Like Sujeet said, oh God, he's going to get very upset and depressed, because the support system after breaking the bad news is not explained to the relative. It's not that we're going to say breaking news like how it is on our shows and say tata bye bye, see you. The point is you break the bad news and you're there for the patient. So being there matters. So the whole problem is, it's not that it is his dirty linen to deal with, because obviously the caregiver is not equipped to deal with the crying and the shouting or the upset and all of that. He has enough other things to handle. So the two things you can't forget is, one is medical ethics, and two, that palliative care is your support, that you as a pulmonologist diagnose, your responsibility is to break the bad news. We collect the pieces after that, because that's why we work in a multidisciplinary team where we address the symptoms, physical, social, emotional, psychological, financial, and what we call as total pain in palliative care language. So if we promise the patient some care of some kind of support, very few relatives will want to take that onus, because patients are intelligent. They know what happens in their body, and they're going to cancer hospitals and not being told they have cancer. So it's actually very betraying for the patient. So I think we cannot afford to forget that. But yes, Dr. Biju will discuss collusion in detail and how to overcome this also in a manner that you can practice and become perfect.
That was really helpful. Thank you, ma'am. Thank you, sir. Thank you.
There's a question from Dr. Raju about, he wants some details about quality of death. Dr. Raju, would you want to ask this any specific question or?
I think Sridevi,
Yeah.
it is going to be again covered in more detail. But having said that, briefly, I would say it's a lot about, from whatever little I understand, maybe Rajam could elaborate, but it's about comfort here and seeing that the patient doesn't suffer, and therefore place room, ward versus ICU. And I think a lot of things is, again, it boils back down to no rocket science here. What does the patient want? Priorities, and you will have patients who are fighters. And, the family tells me the patient is a fighter and he will want everything done. Fair enough. We respect the fact that he's a fighter, but we also want to be realistic with you about his prognosis. And so you can be a fighter till the last breath, but just understand the prognosis. So if you have explained the prognosis, I think the quality of death then is beyond your control, provided you have allowed the patient to have that little autonomy in how he would like to spend the last few weeks, months of his life. Rajam, you want to add?
So I think the quality of death is a detailed evaluation which has been published in the Lancet. It incorporates particular parameters right from the patient's wishes, desires, the caregiver support, the quality of how his distressing symptoms were controlled, the preferred place of death, and whether everything was aligned to his wishes and the patient's wishes. So there are very interesting papers published both in 2015 and recently about how the quality of death was assessed in these countries. It all reflects to the patient satisfaction, the outcome scores. It's a detailed evaluation and ranking. And again, a couple of papers which we are happy to share with you. I'm sure Pallium already has it in their database. And it just reflects, like how Sujeet mentioned, how well patients are dying. And it is a focus on introspection point for us as to how well are we treating our patients towards end of life. So it's not just where they die, but it's how their symptoms, and not just physical, but emotional, social, psychological, financial, as well as the support that caregivers received at that particular time. So we can share those articles also with you of how they rank various countries and where we rank and why we rank 59th.
Thank you, both of you. There is another question about, I think it's more about prognostication when it comes to chronic respiratory illness. At what point, how will we understand the prognostication?
Yeah, so I think, Sridevi, that question, I'm also reading it. I think that's from Dr. Hashmat. And how do you identify someone is deteriorating? I think if you're finding this a challenge, talk to the respiratory physician you're interacting with. If you're not getting the right answer from that respiratory physician, a few clues are lung function, blood gas, oxygen saturation. Three things that will tell you. And I think lung function, a DLCO, for instance, below 30% is fairly severe, restrictive lung disease. Oxygen desaturation on walking, especially if it's going below 87%, significant respiratory disease. Oxygen dependency, NIV dependency at night, significant. And I'm not talking of CPAP, I'm talking of non-invasive ventilation at night. So these are ways you can sense that the patient is getting sicker. So any patient who needs home oxygen, a patient on home oxygen can live for 10 years. Please remember that. They've not reached the end of their lives. But having said that, these patients are going to you need to focus on quality of life moving forward. Likewise, oxygen desaturation below 87, despite having tried treatments like steroids to reverse any parenchymal lung disease, not a good sign. Dependency on other people at home. Any patient with chronic respiratory illness who's dependent on someone else at home, not a good sign. Frail patients. The moment your patient is grossly underweight, frail, these are patients who are deteriorating. And you will get a sense of it, Dr. Hashmat, as you see patients, that this is a patient who is declining significantly, is suffering a lot. They will be visiting you more often, and you will realize very soon that you have no magic solutions in terms of definitive disease-modifying treatments for them. That's when it needs to click. This patient needs supportive care, and you can offer it or get someone else involved to help you deal with it as a general practitioner on a routine basis.
I only want to add one more thing is like we have in cancer, the ECOG scale, Kornofsky's functional scale. When you notice that patients deteriorate in their functionality, increase in their dependence, and it is very clear that it is directly proportional to rapid deterioration or being on the slippery slide. The other focus, which I think as pulmonologists we do not explore, is the mental state of the patient. Very often our patients who are chronically breathless are also depressed or withdrawn, and they do lose the will to live because their quality of life is so bad that they can't even go to the toilet on their own or wash themselves on their own or dress on their own, and they're literally limited to that room that they live with, probably with the caregiver, and it's a social death before a physical one. So all these aspects are important to address, because if you address these pains, the social pain or the emotional pain, the psychological pain, the attitude for the patient changes. Everything doesn't look blurred and dark and depressed. So it's not just the respiratory symptoms that you need to assess, the non-respiratory, he cannot eat, he cannot sleep. All these issues, which again will be focused down the series, are equally important. Imagine being awake the whole night. It is a horrible situation night after night. So many such situations need to be addressed, because once those things affect mentally, the patient's will to live deteriorates. So like I said, we therefore, prognostication, I said, like multiple hospital admissions, walking less and less, more bedtime, requiring higher flow oxygen now, like 4 liters, 5 liters, or even by removing the BiPAP for a minute to eat or drink something is causing desaturation. So a lot of these things point out, and it is not difficult once you have been in practice for 2-3 years to realize this patient is going to be a difficult one, and identify those difficult patients. Not all your patients will fit into that category. Those difficult ones is what you need to either prioritize at the end of your OPD, where you can give them time, address their fears, anxiety, whatever, and then realize, yes, this is the time and this is the patient for integrating. Like I said, that surprise question. In your mind, will you be surprised if he's not alive in the next 1 year? That should be your trigger point to start talking to your patients, and then say, with your permission, I would like to involve another physician of our team, or I think it's time for support care, not just for the patient, but also for the caregivers. Year after year, these caregivers, imagine one person in a family getting admitted twice or thrice a year in an ICU. It's a financial drain. The person who's looking after bedside is not going to go for his job. His family life is disrupted, and we never acknowledge the role of a caregiver in a patient with chronic illness. It's an invisible entity, and the caregiver has to do this for his wife, for a husband or father, mother. It is a duty. It does take a toll on the caregivers, and it's very important, therefore, to address their well-being so that our patient also gets looked after. So very, very important to identify these things. And I'm sure you have noticed these things in your practice. It's just that we are putting it in bullet points. So any of those criteria, again, which is there in the Blue Maple document, as well as the gold standard framework, it really helps you pick up patients with more needs, because palliative care is a need-based science. Some people with advanced COPD have coped well, some people don't, even with mild disease. So because it's a need-based faculty, and if you realize your patient is more in need of your time, of your attention, that also will help if you share that care with the palliative care physician. There's another, sorry, Sujeet.
No, that's fine. In fact, just following up on Dr. Hashmat's question, that it's always good to talk to the specialist you're dealing with as to what more can be done. And respiratory physicians will give you an array of things that can be done, right from pharmacotherapy to say endobronchial valves for COPD, to clinical trials, to invasive ventilation in the ICU, and so on and so on. And when you get all those options, I think those are cues for you as a primary care physician to sit down with the patient and say, look, this is all that can be done if I send you to the hospital. And tell me what you're comfortable with and what you're not. Because remember, when a patient gets really sick and gets admitted, the family often comes back to the primary care physician, and I'm so glad one is on this in this group, and we'll ask the primary care physician, how far should we go? What do you know this patient the best, right? And how far should we go? And you are honestly in the best position to say that, because you have been interacting with the patient on these issues. And the only way you can interact with them is to know from your chest physicians what all can be done. And if you have a chest physician whom you're dealing with who can tell you what they don't advise to be done, that's even better. So you can say, look, I discussed it, and I don't think we should go down that route. But then what do I do if I get breathless? Then we have these options for you. So that's probably the way to go about that. And Priya's question is very valid. It's a very challenging question, and I think this is a superb question for the communication session, I think, Sridevi, which you must keep. I can only say that I would probably, there's a lot of history you want to know here, Priya, as to what really made the patient ask that question. What were they looking for in those 3 years? And if they wanted those 3 years, what can you do to achieve some of that in the limited time they have? And I think it's important to know where that question is coming from. And I'm sure the communication session will help you even better with this. And it's a tough one.
There are a lot of interesting chats happening
Right.
Along with Dr. Priya's question. And I'm glad that Dr. Biju is there. So Dr. Biju will be dealing with the communication sessions, and now he can kind of understand the background. Dr. Biju has also responded wonderfully, like we can be at loss for words,
Yes.
but we can never be at loss for listening. That's the important skill that we all have to learn.
And I think from experience would like to say sometimes patients just want to vent and they really have nobody to listen to. They don't want answers. They don't want to say for every question, they don't want a pat answer. So sometimes they just want to vent. And yes, it might be a genuine thing for this 3 years thing. What I have learned from Dr. Rajgopal, who is the chairman of Palliative India and who's also called the father of palliative care of India, is just stick to 2 questions: what and why. Why do you think like this? Why? What is it that you're aiming 3? So if you keep alternating your questions, you'll hear more and more from the patient. And sometimes just talking, just venting, the patients feel relieved. Like I said in my talk, we don't have solutions for all their illnesses, but addressing, acknowledging, yes, I can see that this is causing you distress. Yes, I can imagine how stressed you must be. Or yes, I can see that this is really worrying you. That acknowledgement also helps the patient. He's not looking for solutions from you for everything. The point is the time factor. The point is the quality of listening. The most important thing that Dr. Biju will tell you in communication is to not talk, is to hear. And that is very important, which we don't. There's research to say that we interrupt patients within 1.8 seconds of the patient opening the mouth, because we really want to just keep moving and come to our agenda. It is not about our agenda. It is really about the patient's agenda, especially in a patient whose distressing symptoms are not going to go away. He just wants to vent. Sometimes we really don't have answers for these patients. And we really need to listen and say, yes, I can see that this is distressing. Or yes, how do you think we can? And flip it back to him, because he should be in control of his situation. How do you think we can address this? Suppose they say that the daughter-in-law is being rude, or somebody's not even feeding him properly, or nobody's talking to me. So we go back to saying, why? What do you think? Why do you think it is it? Can you think of a suggestion? Because family dynamics is something that we really can't get into. So give the control back to him. And sometimes they really just want to vent. There aren't any answers for all their issues. But the point is the time that we give them to hear them. That is very, very important.
And I don't think we should ever assume, Priya, that we know this patient will not live for 3 years. So, I mean, if the patient perceives that they're not going to live for 3 years, they've understood it. And you don't have to tell them, oh, it's true, because we don't know if it's half a year, 1 year, 3 years. And your prognostication, I think, in terms of chronic respiratory disease is not easy at all. And why is it not easy? And I can tell all the chest physicians on this group is because of medical technology, right? So you have non-invasive ventilation that has prolonged lives at home. Patients on NIV live longer at home, COPD. Patients with ILD are living longer because of NIV, but are suffering more because of NIV. So these are very important issues, and you need to balance the suffering with the availability of that technology. And I've been getting questions now, and when we were writing a paper recently about high flow nasal cannula and treating these patients, high flow nasal cannula can only be given in a hospital. I mean, imagine getting that set up into the house now. So Wealth can do all this. They can get an compressed oxygen in their building and give high flow nasal cannula for palliative care, which is ridiculous when you look at it. But there are no end to questions about how you can prolong life. It's really what the patient wants out of that quality of life. Yes, Kiran Vishnu is asking about morphine in neuromuscular weakness. For sure, we have used it, and we'll hear more about that. And
so I also want to tell you that is what makes palliative care integration in non-cancer difficult, the unpredictability of the illness, and which is why our patients are deprived, because we feel, how can we refer? He's going to live for another year. But the quality of life definitely changes with palliative care. And Sujeet, one of the things I've learned from Dr. Biju about assume is there's a joke in palliative care that assume is actually making an ass of you and me. So that is something that you should never do. If you spell out assume, it's really making an ass of you and me. And that is something we should never do with patients. And nothing that patients say should shock us or surprise us. And we really need to be as non-judgmental as we can, because we are their sounding boards, and we really need to train ourselves to keep quiet and listen.
Yeah, listening is key. And it's something we just don't have time for, right? Listening. I think you realize, that, and someone actually told me this, that people spend less time on a hospital round than in their clinics with a particular patient, So, and actually the indoor patient needs more time from you than the outpatient. And when you reflect on that, you'll realize why patients get dissatisfied when consultants visit them on hospital rounds, So some patients may not need much time on the round, but very often they need a little more time than the outpatient. So when you actually think of that, when you go for your next round, I think just factor in that there are things that the patient wants to ask you. He wants you to just sit down and talk to them. One patient actually told me the consultant I referred to him had his hand on the doorknob of the room. And it was so embarrassing because, he said, which was his consultant he referred, because the moment he came in, his hand was on the doorknob waiting to leave. So, when you do these small things, I think patients are very good at perceiving which consultant is actually bothered about what their issue is and which consultant wants to, quickly depart.
Thank you so much for the wonderful discussion in the chat, as well as the questions that were asked, because that's how we get maximum benefit out of this session than just listening and leaving. But we also learn from you. Yeah, so I think we have 15 minutes to go. We have a case presentation. So today we are doing the presentation for the sake of following the format. So you'll understand how the discussions are going to be happening in the coming weeks. So I will take rest of the questions maybe after the presentation. This will be a very short, the case presentation template is sent to you all. It's like 5 to 6 slides, major points that needs to be discussed, which should match with the topic, with the session for that day. So today I'll be presenting from my side. So I think it's totally from a palliative care perspective, where we get a referral from the respiratory physicians for managing a patient with breathlessness. So I'll just start my screen. Rajlakshmi, it's visible, right?
Yes, ma'am.
So this was a 24-year-old female referred to us with breathlessness, and she was diagnosed to have interstitial lung disease. And this, in the reports and whatever details are there, that's that was just what we got. So I have included whatever we had during those referrals. So she came to us with severe breathlessness and cough. Initially, her husband came to us because the patient could not travel because she was at home on continuous oxygen and still breathless. And she was coughing all through the night continuously. And when she coughs continuously, it starts giving pain on her chest and abdomen. And she's unable to sleep or move around. So she's literally on oxygen, awake all the time, unable to sleep and doing her daily activities. And we also felt really sad because she was very, very young. She just got married a few months back and she developed cough. They consulted a nearby local hospital and then they told to do the basic investigations, X-ray and all. Then they started her on some medications and they told it must be pneumonia. But later on, when this breathlessness kept increasing, they referred her to Medical College Trivandrum, and initially they diagnosed with cryptogenic organizing pneumonia. But there were a lot of back and forth investigations and discussions happened in the respiratory medicine department, which I have not included really, but this was the end diagnosis that they came to. She was pregnant a few months later, and then it increased her breathlessness. And by 20 weeks, they had to have a medical board discussion that she cannot go ahead with the pregnancy. So she had to terminate at 20 weeks. And initial days, even with breathlessness, she was able to manage her activities of daily living with a little bit of pacing and slowing down her thing. But later on, when the dyspnea was increased, she was on NIV, which she did not tolerate. These were all from the referral papers and from what patient told us. And then they changed her to the nasal prongs. And the breathlessness kept worsening day by day. And then they told you can go home with oxygen, arrange for oxygen at home. And she was unable to sleep, unable to walk. And she was referred to us for management of breathlessness. So the husband came to me, and while telling all the story, he started crying because it's so early in their marriage, and then they had to deal with a lot of stuff like hospital in and out, and then a lot of investigations to come into a diagnosis. And this were the basic examination, and her dyspnea was so severe, and it was grade 4. As I mentioned, sleep was very much disturbed. She couldn't eat because while eating, she becomes breathless. So she was scared of eating. I don't want to eat because it makes me so breathless. She scored her dyspnea 10 out of 10 severity, nothing less than that in last few months. And as was mentioned many times in the presentation, she was very, very anxious. Whenever she was breathless, she was very anxious. She just calls every one of us and be with me. I think I'm going to die now. I don't want to die. I want to live. I just started my life. So these were the conversations that she was having. So these were the treatment and significant investigations that we have received from the referral letters. She was given different class of antibiotics. I think at least 5, 6 back and forth of antibiotics. And I've mentioned the chest X-ray, bilateral reticular nodular opacity, CT scan was done, and I am not reading out everything, but echocardiogram was normal and procal was negative. They did an ANA profile, which was again normal. And coming to the psychosocial part of it, she was very young, married a year back, and herself and her husband and his mother live in a house. So the husband was an electrician, and which was the only source of income for the family. For the last few months, he's not going for work because he's the primary caregiver for her. And he takes care of her like very affectionate person, very caring person. He's there with her all the time. He had to mortgage their house because they were not from Trivandrum, so they had to travel back and forth every now and then. And this hospitalization, ICU, everything cost a lot for them. Then they had to rent an oxygen concentrator at home. And initially he could afford that, but then later on he could not. So both of them were worried about their future. How am I going to live with this oxygen forever? I can't even remove it for a minute. She could not even discuss about removing it. Then she becomes anxious. So it's like depriving me of my life. So she could not think of taking it for a minute. When am I going to have a normal life with my husband and family? Am I going to die with breathlessness? Both of them were really not aware of the prognosis, but I understand from the documentation that there were multiple discussions happened and documented about the illness. But from the patient side, they did not understand anything. They did not understand. They were not aware of the prognosis. And we could discuss the prognosis with her husband initially, but then he was so much in distress, and then he wanted to explore more to save her life. That's when he understood that, okay, this is progressing, and there may not be any comeback to a normal, so-called normal life that they are expecting. And then he really wanted to explore to save her life. This were the medications when she was on when she came to us: steroid, iron, calcium, and metered-dose inhalers, montelukast, and pantoprazole. We started her on low-dose morphine. I'm not going into details of what dose of morphine we started and how we titrated, because we'll be coming to that in detail on one session. But we started her on low-dose morphine. After a few weeks, both the husband and the wife slept well at night. The next day, the husband was so thankful that he could sleep. And she was so thankful that I could sleep. I could sleep for a few hours in a room after a long time. And her ADLs were slightly better. She could move around a little bit without oxygen on and off. The score was still 5, but she could sleep well at night. So these were the main concerns. When am I going to be normal without this prongs and stuff? When can I walk around? I'm literally bedbound now. I want to walk around without oxygen. I want to sleep properly. Not just for the patient, even the husband told me that we want to sleep properly at some point in time. And she kept asking why my asthma is not reducing. People use inhalers and their asthma get cured, but my asthma is not reducing. So in summary, this is a 24-year-old female diagnosed with ILD, breathless, even with continuous oxygen. And she was referred to us for supportive care and symptom management. They wanted to discharge from us after he started exploring new options, and someone suggested lung transplant, and it costed a lot. And they started fundraising through the social media pages, because even the private hospital people told she's very young, this can be a very successful treatment, but they were very, very, very poor. They could not even think about it, but the husband did not want to give up if that is an option. So we do follow-up calls, even if they get discharged, just to see how they're coping with their life, just to see how they're doing with their symptoms. So on a follow-up call, we understood that she was on ventilatory support, and the family was totally devastated due to financial issues. The husband was literally living in that hospital. He looked really worried. I mean, he sounded really worried. He was so distressed, and still they were given high hopes that it might be a possibility to have lung transplant. And we have covered most part of it, when to integrate. So there were 2 referral points for this patient. Initially, she was referred to us by the respiratory department in the medical college when she was breathless at home, and where they were not able to manage the finances and they were not understanding the prognosis. The second referral was from a private hospital when she was totally on a ventilator. So these were the 2 points of referrals came to us, but unfortunately they were still on high hopes, and she died on the ventilator. She was away from her husband. She died a few months back. But I would really like to give a discussion or thought, at least, what as a pulmonology or chest physicians, what do you expect the role of a palliative care team here in this? I understand that Dr. Rajam and Dr. Sujeet has very well elaborated on the role of palliative care team, but you can understand people refer to us many a times without, as Dr. Sujeet was mentioned, this was not a smooth referral. The patient was literally referred to a new phase where we are telling them about the prognosis, and they have not heard it from their respiratory physician. So then we become the bad cop. Then they may not want to believe a person who just met a few days back. So these were the issues that we were facing as a palliative care team. So I would like to stop sharing here, and I think
comment from Priya saying some don't want to hear. Yeah, but there's a reason, Dr. Priya, that they don't want to hear. And that is what we need to explore. I mean, imagine a 24-year-old with any diagnosis, which is life-limiting and life-threatening, is a sad, earth-shattering, life-changing event. I mean, even in an 80-year-old, we have people who don't accept it well. So I think at 24, it is important. And that is where I think our entire skill of communication, how to say, when to say, how much to say, and then explore, because 24, recently married, there's so many issues, sexuality being one which we really are uncomfortable in dealing with when we talk to young couples. We are so uncomfortable in bringing about. In fact, this is one, when a patient brought it out to me and I realized, yes, I completely forget about that. I'm so focused on breathlessness, money, social, emotion, that sexuality is something which is so important to address. And it's a very sticky issue to address. But there is so much going on in the life of this 24-year-old where life has just begun. Yes, it is something that we don't want to hear. None of us want to hear bad news. But it also means how we say it, when we say it, and how well we support it. What really hurts me is the fact that this poor family had to spend so much money and then even end up in a ventilator, which means I don't think even he had money to live after her death. So it's not just the fact that the patient died, but imagine his life to resurrect it from where he was in an emotional state and a financial state to come back. So it's not just the person who is gone. And another paper which highlights this is that, which Dr. Rajgopal always quotes, that in India, the staggering figure of 55 million people who go below poverty line trying to keep their loved ones alive in the last 2 weeks of life. So we have to think of the health economics also. And I'm not saying that this person was not an ideal candidate for ICU at 24, but age is not the only factor. It's important to remember if she is going to be a good candidate for ICU, because in a pandemic situation and in a resource crunch country, we really need to put the right patients in the ICU. And according to statistics, 25% of ICU patients should not be in ICU in the first place. And like Sujeet said, money should not be the dictating factor to admit in ICU. He can afford it, so let him be on ECMO and let him be on ventilator. So it is a very sad thing for a 24-year-old to get an interstitial lung and unfortunately also die on the ventilator. So across her journey, there was only suffering of various kinds. Sujeet.
I think I'll just add to that. There are 3-4 things, Sridevi, we need to factor in here. One is it's always more difficult the younger the age of the patient, always. And pediatric palliative care, I mean, I'm just amazed at some of the work happening in Mumbai. It's not huge, of course, but whatever little work is going on is outstanding. It's much more challenging the younger the patient. But whatever the age of the patient, the second thing you need to look at when a patient is young is how much do you know of the diagnosis? So the second point I'd put when you see a young patient is, are you sure what the diagnosis is? And if you're sure what the diagnosis is, have you explored every possible treatment for that diagnosis? That is important in a young patient. I've been caught on the wrong foot here, so please remember that don't write off something when there is something potentially reversible. So when Sridevi, you brought up in that case perivascular peribronchiovascular consolidation. The word consolidation potentially means reversible, right? Or it means it could be a malignancy sitting there, bronchoalveolar carcinoma. So the moment a good CT radiologist has reported consolidation, you need a biopsy there. You need to know what's going on. I mean, the often, thought thing is, okay, give steroids, cryptogenic organizing pneumonia, give prednisolone 30 milligrams a day. Fair enough, but your patient is not improving on 30 milligrams a day. And the family and the patient wants an answer. So then I would say, do a CT guided biopsy of that lesion, bronchoscopic if fit, or whatever your interventional pulmonologist is good with. But it's extremely important in the younger age group, in this type of a patient, to know what the disease is and whether it can be reversed. Now, when you know that it's not reversible, that's when the difficult dialogue starts. And I mean, obviously that'll be covered in another session, but that's when you need to really sit down. So spend some time on that. It shouldn't be that you suddenly refer to palliative care, and the palliative care physician is also confused. Has everything been exhausted? This patient is so young. So as a respiratory physician, our responsibility is to be sure that there's nothing more that can be done disease specific, then only reverse. And then finally, in a young patient like this, what is the comprehension of the patient? How much does the patient actually understand what you're talking about? Because sometimes we have this continuous diatribe of dialogue that we give, and the patient has understood nothing. Yesterday, I met a patient who has been counseled the same thing by 5 respiratory physicians. And after I told him the same thing for the 6th time, he said, I forgot what you said. So it's, short-term memory loss. He was sleep apneic, obese, heart failure, but he just wasn't using his CPAP. And he was forgetting what the consultant had told him about because he had untreated sleep apnea. So it finally boils down to comprehension. If he doesn't understand, is his caregiver understanding? And can that caregiver explain to the patient, with much more time, what you have been trying to explain to the patient? So a lot of this requires time, so age of the patient, understanding the disease, reversible or not, and understanding patient's comprehension. Time is so precious, but this time invested with even one patient pays tremendous dividends in terms of patient satisfaction and your own respectability in society. Just these few points, one could discuss this case for a long time, but just these few points, Sridevi, that are fundamental to this case. Then, of course, you described the second referral was straight on the ventilator in the ICU. And obviously, there must have been 10 reasons why that happened. And one could go into all those reasons, but it's usually the reason is that no one said anything, and no one told us not to go to an ICU, or no one told us not to be put on a ventilator. Because if you start discussing ventilation on the first day of palliative care, your patient's going to run out of the room very often. And we've had that experience, Rajam and I, where Rajam's discussed it early on probably, and the patient said, my goodness, it was so depressing, the conversation. So there is a way you slide into that, and the patient will give you an opportunity to discuss it at an appropriate time. And when you see such a patient, and we have seen this happening in our casualty, where the relative said, but the last chest physician told us not to put the patient on a ventilator. And then then I asked them, but why did you bring the patient to the casualty and allow intubation? But they didn't tell us what to do if we don't put them on a ventilator. So there's the deficiency. You get my point.
That's the other thing, that doctors tell you what not to do, but never tell you what to do. Yeah. And I think that's what palliative care does so brilliantly. Like, don't bring to hospital is not the solution, but what to do at home is the solution. Yeah. Or whom to contact. Have a checklist. What will you do when this happens? Whom will you call? What medicine will you give? So those are the things. So I think palliative care, that way, hand-holding is telling you what to do when you know your goals of care.
And also use time effectively. I think Biju mentioned it in one of the chats that if you are good at communication, your time actually reduces in practice. And many people think to communicate all this, they need huge amounts of time. No, you don't. If you learn communication skills well, you figure it out well, you will realize that you actually save time by effective communication and you don't waste time.
Yeah. And I think another point which I want to make it, a good communication is always remembered and a bad communication is never forgotten. Second thing is, most lawsuits in the Western world are because of lack of communication. And I think that's so important for us. This is because we don't talk is the reason. If you communicate it to people, they will, and they have understood, and you have documented, you are not going to be sued. So it's very, very important to learn the skills of communication. It cannot be overemphasized. It is very, very important.
Thank you so much, everyone. And thank you so much for the lovely chats coming up. So these are really encouraging discussions and exciting program. Thank you so much, Dr. Rajam and Dr. Sujeet, for the wonderful session. And thank you everyone for the interaction. Rajlakshmi, do you want to conclude?
Thank you all for that interactive session. Am I audible?
Yes, you are.
Okay, thank you. Thank you for that interactive session.